Good evening, everyone. On behalf of the organizing team, I warmly welcome all the respected faculty members and the participants for today's online lecture. A bit about today's this lecture series that has been going on. The Department of Psychiatry, D.Y. Patil Medical School, Navi Mumbai, has always attempted to pursue academic excellence. And we had started this PG lecture series under the leadership of Dr. Ashmin sir, and it has been going on for the students in and around Mumbai region since 2015. As an extension to it, we have now started presenting this lecture series in the video format also, which is accessible online even after the lecture is done. This lecture series helps the PG students to expose themselves to the varieties of expert or from all over the India, rather all over the world now. We hope that this helps the PGs and the psychiatrists all across the country and now over the world to enhance their skills and knowledge. We continue to strive hard to make further advances in our teaching efforts. Today, it's my privilege that we are having with us. Next slide, please. With us, a very esteemed speaker, Dr. Anita Shyam ma'am, who will be talking about overview of sexual dysfunction. We have with us Dr. Rajeshri Ray, who is professor and HOD from Durgapur, West Bengal, who will be moderating today's session. Next slide, please. So about the moderator ma'am today, the Dr. Rajeshri Ray, she is MD, FRC Psych with the other degrees, and she is the HOD at Durgapur, honorary member of World Psychiatric Association, chair of South Asian Division of Royal College of Psychiatrists, secretary on the section of religion, spirituality, psychiatry, World Psychiatric Association, and also a very multifaceted personality where she has other skills also as a dancer and artist by passion. So thank you, ma'am, for consenting today to chair today's session. With this I request you to take over the proceedings and introducing the speaker for today. Thank you, ma'am.
Well, thank you,
Sorry to cut in, Dr. Ray. I'm sorry for the intrusion. I'll take this opportunity to also welcome on board Dr. T.S.S. Rao. We are privileged to have him with us. He is the president of the IPS, and he is one of the leading figures in the country on sexual medicine and sexual psychiatry. So welcome, Dr. Rao, and we are happy to have you with us. Over to you, Dr. Ray. I'm sorry for the intrusion.
No, thank you. And I think it will be my privilege and a great opportunity and a blessing if Professor Rao co-chairs this session with me, sir, and helps to moderate, because I can't think of anyone beyond him for this talk. So Professor Rao, I hope you can stay with us for the entire duration and co-chair this session with me. Is that all right, Dr. Rao?
Sure, I will ask the
okay.
to make him a co-host because he would not be able to access.
That is fine. Great.
So
please
make it, sir.
Yes.
Please do. Please do. It's a great honor for this whole sort of all of us here today. Well, good afternoon and evening to everyone. It is my privilege to jointly chair this session today on this overview of sexual dysfunction. As we know, sexual health is increasingly being recognized as an essential component of the overall well-being, and sexual dysfunction is remarkably common, with studies suggesting that nearly 1/3 of men and maybe up to 40% of women will experience some form of sexual difficulty during their lifetime. However, we realize that there's a lot of underreporting, there's a lot of frequently overlooked practices, mainly because of stigma, cultural barriers, or just discomfort when people come to discuss sexual issues. But this is an opportunity really to listen to someone who's worked incredibly exploringly in this area. And this is an opportunity for the PGTs to really look into the latest evidences, the latest pharmacological therapies, and the importance of the biopsychosocial model and relational perspectives. I'm sure today's session will help us to better understand these dimensions and remind us that addressing these sexual health is a very important part of holistic patient care. With that introduction of the topic, it is now my pleasure to invite our esteemed speaker, none other than Dr. Anita Shyam. Good evening, madam. I'm glad you have made time to be here with us today. And you're actually in India as we are hosting this session. Madam is an integrative psychiatrist and a sexual medicine specialist, a clinical sexologist, and a sex coach. She is the founding member and the CMO at Curix RX Men, and she's a NLP therapist and a hypnotherapist and practices spiritual and pranic healing practitioner. Fantastic and incredible portfolio. You realize she has been a university topper with multiple awards and achievements, and in fact, since 2002 has been India's first clinical sexologist and a sex coach. She's given talks and lectures in multiple national and international forums and has published widely in national and international journals. Over to you, ma'am, on that note.
So, hello everyone.
There is an echo. Sorry, is that from my end?
No, I don't think so.
Okay, so on that note, over to you, ma'am.
Well, thank you everyone for joining for this lecture, and I want to personally thank Dr. Rashmin for giving me this opportunity. And I also want at this point of time thank him for being so persistent. I know it's been since last year he's approached me, and I haven't been really got a chance to deliver this lecture because of a lot of other commitments. And I'm sure Dr. Rao should really echo this with me that I have been all around with a lot of commitments. But I am so grateful to Dr. Rashmin for giving me this opportunity, and rather, I want to be grateful to him for another cause, that to bring such a delicate topic at the PG level, because I didn't have that privilege, right? I didn't have that privilege of learning about sexual dysfunctions in my PG days. And as Dr. Ray mentioned about all the factors which lack of reporting and lack of knowledge, but even lack of training to our medical family is one of the main causes that people are not really open to treating sexual dysfunction. So I'm so grateful to Dr. Rashmin to bring this topic to his PG students, giving them that avenue of learning at this time of their career. So with that, I'm going to start my presentation, and we're going to talk a lot as I present. So here you go. And right. So the goal of this presentation is going to be definitely to teach you guys what different aspects of sexual dysfunctions men and women face, but also I try to show you some videos which helps you in a technique called as SARS. So SARS is a sexual reassessment, or SARS is a sexual attitude reassessment. This is done worldwide, especially in the United States, where people who are practitioners of sexual medicine are rather sensitized or desensitized, and these videos help them to go deeper into their own sexual values, because of course we don't want people to be having those transferences, counter transferences when they are teaching, when they are dealing with sexual dysfunction patients. So I try to show you some videos. Of course, they're take home messages, because you're going to learn a lot, but also is that is sexual attitude reassessment. So let's move on with our topic today. As we know, sexual dysfunction is a huge topic, and giving me just 45 minutes would not really, it's not going to be possible for me to cover every aspect of it, but I'm going to teach you certain strategies, certain techniques which you can use directly with your patients. And as PG students, you're going to learn different techniques which are so unique in this practice, which I have learned in last 25 years. So this is me, and I always believe that all these introductions really mean nothing if I am not able to deliver, or if I'm not able to teach you what you really want to learn. So everything comes with whether I do a good job in this presentation and how do you feel about my presentation. So today's goal is we are going to do an overview of sexual dysfunction in men and women, that's male and female, and also learn the different assessment management strategies if somebody comes to you with sexual problems. So averagely, this is going to be a very common question asked to you guys. What is the regular frequency of sex? So this is a research which was done. Don't have citations, but any of my presentations or any of your slides, if you are looking for citations, please reach out to me. But in an average adult has sex almost 54 times per year. These are just numbers, okay? About one per week. There are more, there are less, but adults in their 20s have more sex as compared to adults in 60s who have at least 20 times per year. But in my clinical practice, I have a patient who is almost 85-year-old and definitely has sex once a week. So these are all numbers just for your knowledge. Now, very importantly, we want to know what is a sexual response cycle. I think you guys learning at this age is a big asset for you. It's going to be it's a privilege for you to know what is a sexual response cycle. So anytime in our life we are exposed to a stimuli, whether man or female, there's a cascade of event which happens, which is a sexual response cycle. So not only the physical, but also the various emotional changes which leads to a desire, which leads to arousal, then leads to orgasm. And depending on how is your experience, you are then willing to go into another cycle at any point of time. A good thing for you to know is the beginning of the second stage of desire will start as soon as you end one sexual response or one sexual act. So as you see, this is called a non-linear model, because as we move on, and I'm going to teach you some more different models, but this particular model is worldwidely accepted, that your sexual response, whether it is man or women, sexual response is not linear. That means it doesn't follow one step and two step and three step and four step. It is an intermingle of all these four stages, which is again desire, arousal, orgasm, and a refractory phase. So let's see something more. So, so there are four different models which is widely accepted. One is the Master and Johnson, which is the MNJ model, which was thought to be a very linear, that each step has to be followed. Like desire has to, arousal has to be followed by desire, orgasm has to follow arousal. So, but what we found, and the scientists or the researchers found, that sex is not linear. But again, this is another model which was followed by the MNJ model, which is the Kaplan, and it's the three-stage model, which is the desire, excitement, and orgasm. And according to Kaplan, these stages were more extensive rather than the shorter phase, where the MNJ thought that it is a desire which is the longest phase, then there is a plateau, and then orgasm is the most shortest phase, and then is the resolution. So this is again a linear model, which is a three-step model. But the widely accepted is the Basan model, which is a circular model, where anybody who is exposed to a stimuli at a neutrality can, if the person is willing and motivated, we're going to learn, when the person is willing and motivated, can indulge into a cycle which is called as a spontaneous or a responsive cycle, to get aroused, to get desire. And when there is this interplay between the arousal and desire, one is now interested in having sex, leads to a phase of pleasure, which is orgasm, and which is followed by a state of now motivation or willingness to be involved into another cycle. This is the Basan model. And lastly, the most newest model is the incentive model. What is this person getting out of getting being involved into sexual activity or a sexual response? That is called the incentive. Now, incentives can be positive and incentives can be negative. And once it's a negative incentive, a person is not motivated to get involved into another sexual act. But if the incentive is positive, there is love, there is respect, there is nurturing, there is pleasure, the person is then interested in getting involved into another sexual act. So we have the MNJ model, we have the Kaplan model, we have the Basan, and we have the incentive model. So, what are the take home message and why you want to learn about the sexual response cycle is because the sexual pleasure and satisfaction are not reliant on orgasm, though orgasm can be a nice bonus. It can be cherry on the icing, but all you want is pleasure and satisfaction and that bonding. Sexual desire doesn't always have to come before sexual arousal because a person can get aroused and then develop desire, which is a very, very common phenomena with women. So her husband comes and kisses her, touches her. Man, when his partner comes and kisses, touches, shows that seduction, a desire can be built. So sometimes getting physical and experiencing arousal can elicit desire. External factors such as relationship dynamics, intimacy, rewards, incentives, pleasure can play a very important role in sexual response. Sex is all about pleasure and satisfaction. It is not about achieving a goal, and that's when the struggle begins. Shift the focus to you and your partner's sexual response. Communicate your desires, communicate your need, and the pleasure is then yours. So these are the take home messages why you want to learn the sexual response cycle. Now, Madam was just talking about the biopsychosocial model, of course, widely known and used in all our fields. But right now, there were recently the two domains also added, which is the spiritual aspect and the sexual aspect. That's why when we now talk about the domains, the etiological, the pathophysiological domains, we talk about the biological factors, we talk about the social factors, the psychological factors, the sexual factors, and the spiritual factors, where biology means all about the medical aspect, the hormones. The social aspect is the cultural aspect, the negative messages, the upbringing of this person, the dynamics. The psychological aspect is depression, anxiety, the dynamics in this relationship. Each person as an individual, what psychological factors he or she brings in this relationship of sex can hamper or affect the sexual functioning. The sexual aspect, if any of the partners are suffering with any other sexual problem, that becomes a factor to affect the other partner. And of course, spirituality. I have a friend who suffers with immense sexual dysfunction because he says, Anita, I don't really understand. There is Monday, the Shivji fast, then we have Tuesday, Ganpati fast, and my wife is so spiritually inclined that sex becomes with out of our bedroom because there's so much of spirituality. Secondly, we also have to keep in mind about the spiritual practices or religious practices of certain religions. Whether when we come to talk about Islam, I remember about this particular couple we had, and the couple, the husband came to us with sexual dysfunction, erectile dysfunction, and going deeper into the history, we found out that because of religious reasons they cannot have sex in the morning because they have to pray. During the daytime they cannot have sex because it's a smaller house and the wife is always busy helping out in the house chore. So going deeper and understanding their lifestyle, we found that we could find a window in the afternoon. And that's what changed the whole chemistry, that the simple guidance, going deeper into their history and understanding how does this dynamic of this family works, giving them strategies that you could find a small window in the afternoon, and that miracle, that played a big miracle, and we could help this couple come out of their sexual problem, which or sexual challenges they are facing. So this is an interesting algorithm which is called the relationship triangle. This was given to me by a close practitioner, a close friend, and this is called a relationship triangle. And remember, everything what we learn today has a very significant role because you are going to help your patients. So this is one partner who comes to you with a sexual problem, be it a man, be it a female. You always want to also analyze and assess the partner, right? So this is your patient, this is your partner, and we also want to see how is this phenomena affecting their relationship. So this is a relationship triangle. Now, when we put a perspective of the biopsychosocial and spiritual model along with the sexual response cycle, this will help you to understand. So, where is the challenge? Where is the real challenge here? Is it some part of their sexual response of this patient of yours, and what are the factors which are affecting these patients? Is it the biological factor, is it the social factor, psychological factor, sexual or spiritual factor causing this sexual challenge in this person, and what is this whole phenomena affecting this partner, right? So, and we are going to see very soon why this becomes very relevant. So if we go deeper into analyzing and assessing the partner of this patient, we want to go deeper into the biology, the psychology, the sociology, the spirituality, and the sexuality of the partner, and also which aspect of sexual response cycle is affected in this partner, and how is this affecting their relationship. You as physicians who are right now learning about sexual medicine or sexology should be able to understand sex is not one person's problem. It is not one person's pleasure. It is the one partner, second partner, and the whole relationship which is involved. So let's see this beautiful video and let's understand what am I trying to tell you.
क्या आज संडे है
So here, this beautiful video is about a partner who is not satisfied. She can literally count for how long the husband can stay. So exactly when you bring this particular video in terms of the relationship triangle, you'll get to know maybe if the male partner comes to us and says he's got PME. Are we just going to treat the PME part? Are we not going to look at the other partner who probably has no orgasm? She does not having pleasure. Or if this partner, the female partner, comes to us saying she probably has pain because she is not aroused, she has low desire because she doesn't want to have sex, and are we not going to look at the partner, right? And overall, what is this dynamic causing to this relationship? Are they happy in their relationship? Does she feel satisfied in their relationship? Becomes a big question, and that's why this algorithm is very important. And I want you guys to remember this video even till we reach the treatment, because there we are going to find treatment strategies to help the patient, the partner, and also how we can flourish their relationship. Sorry. Okay. So since we learned about the five domains, we learned about the sexual response cycle, and we learned about the relationship triangle. So any problem in the whole dynamic can lead to sexual dysfunction, which is a difficulty or a challenge experienced by an individual or a couple during any stage of this normal sexual activity, including physical pleasure, desire, arousal, or orgasm. So any challenges in their sexual response cycle can lead to sexual dysfunction of one partner, which can also cause dysfunction in the other partner, causing extreme distress in their relationship. And the distress is self and the relationship, and has a profound impact on the quality of their life, or the quality of their relationship, and quality of their sex life. And DSM-5 has been very kind, and they have given us subtypes or specifiers, which are these problems can be lifelong, right? Men can have premature ejaculation, erectile dysfunction, which has been lifelong, right? They can have early ejaculation, delayed, which has been lifelong, or it can be acquired after a normal phase of sexual functioning. The problem began. That means they acquired this problem, and it could be various other factors. The sexual problem can be generalized. It's present all the time with all the partners, or it could be situational, or it could be specific. That means a female can have low sex desire or pain whenever she's having sex with a partner in their house, where there are the entire family members, or she could have he or she could have sexual dysfunction with a particular partner, whereas with the other partner he or she might be completely fine. So specifies here, is this and you need to take a detailed history for these specifiers, because your strategy or treatment will change. So we have lifelong, we have acquired, we have generalized, situational, or specific, or it could be due to psychological factors, it could be due to organic factors, or it could be a combined effect of all the factors. So, sexual dysfunction, any individual can have one or more sexual dysfunction at any point of time. And as Madam did mention, we have higher number of females suffering with sexual I think it is 47 to 53% here. 43% of women suffering with sexual dysfunction of any kind in their lifetime, and we have 31% of men who suffer with sexual dysfunction. We have the DSM-5 and the ICD-10 who have been kind to give us different classifications. So we have here sexual desire, where when men and women can have low sexual desire. Females, recently DSM-5 has clubbed the classification to female sexual interest and arousal disorder, because remember we talked about the Basan model, where there is where the arousal can come first and the interest can be built. So that is why they have clubbed this condition together to female sexual interest and arousal disorder. We have orgasmic disorder, which is for men erectile dysfunction. We have premature ejaculation, delayed ejaculation. There is also an ejaculation. A female can have orgasmic disorder where there is minimum orgasm or absolutely no orgasm present. There's another classification of sexual pain disorder. We only talk about female, but men also suffer with pain. Yeah, we tend to forget the men, but females suffer from the genitopelvic pain penetration disorder. Right, men also suffer with pain disorder. The causes can be various other reasons, and the classic DSM has also involved the substance medication induced sexual dysfunction. We are not going to discuss about paraphilias, dysphorias in this particular lecture, but I hope Rashmin can get some expert, or maybe someday I can teach you about the paraphilias, gender dysphorias. Also, why not the kink behavior, the BDSM behaviors, right? Why can't we involve the LGBTQ group also in our presentation, so you get this holistic learning about sexual problems? But now we come on to learn about how to assess and evaluate these people who have come to your clinic, men or women, right? So sexual complaint confuses clinician, because we tend to forget one thing, that sexual response is a state dependent phenomena, not a trait. This is not a trait of a person. A person can be tired, a person can be frustrated, a person may be having metabolic problems, a person may be on antidepressants, a person may have challenges in their relationship. It could be also induced by alcohol or drugs. So it is a state dependent phenomenon, not a trait dependent phenomenon. That's why the treatment becomes easier, because you're ready to treat the state. Now there is a strong influence of context, relationship, and the meaning what sex brings into these people's life. So you want to always inquire, how is your relationship with your partner? What does sex mean to you? What is the importance of intimacy in your life, in your relationship? Now, risk of pathologizing, over dismissing, right? We want to run to diagnose people, but we do not want to go deeper into the history. I see physicians, especially in India, where they want to see patients for a minute and come to diagnosis, rather than really going deeper into what is the relationship doing to this person. Is this sexual dysfunction because their partner has a problem, or the relationship is a problem, or it is a holistic problem? So rather than really pathologizing this whole phenomena, go deeper into the history and see what are we forgetting in this analysis. So, evaluation and intervention model used in clinical practices. There are three different popular models which are available, and there are multiple rather, but let's focus on three. The most commonly used model is the implicit model. So, what does this models mean? These models basically help you to assess, evaluate patients, and come up with a proper treatment or intervention plan. So, very commonly is the implicit model, which is any patient coming to you or in your OPD right now. You guys are PG students, so if you want, right, if you want to become a sex med practitioner or even not become a practitioner, just become more sensitive to this topic, give them that liberty, give the patient the liberty to talk. So you give them the permission, like, hey, you know what, how is your sex life? Is everything good in your intimate relationship? That means you're giving this person a permission. I'm ready to listen to your problem. With permission, once you've heard the problem, you give them limited information. Yes, PMA is a very common problem. 1 out of 3 and 4 men suffer with this problem. You give them specific suggestion. It is an anxiety related issue. So, are you feeling anxious with your partner? Did you ever have a negative experience? Okay, how about you learn some relaxation strategies? How about you just talk to your partner that, hey, this is causes anxiety in me, and that's why I come too fast, and I really, this is not what I want to do. And you give them intensive therapy if required. If you can refer them to a practitioner, or if you are well versed with the therapies, then you go on giving them therapies. But the other two models are quite similar. It is the allow model and the MEEBS model. MEEBS model is by Dr. Brighton, who's my mentor in sex coaching. But the allow model is also ask legitimate questions. There are certain limitations. Up and work together as a team with your partner and with your therapist. MEEBS model is the mind, emotion, body, energy, and spirit, because Dr. Brighton believes a lot in the energy and spirit. So whenever she's treating a patient, she wants to know what this person is bringing in the therapeutic relationship and also in the relationship. So there are these two models commonly are the implicit model. So what should be the goal of your treatment? Your goal of the treatment should be first is treat the cause which is causing this problem, right? But the goal should be creating a sex positive, open minded, body experiential based approach, which is very client centered and goal oriented, because there's a purpose you're doing this treatment. And it has to be result driven, because nobody comes to you again if you're not going to give results, right? So that could involve psychological counseling, adopting treatment procedures to improve the quality of their relationship, not just the marital life, but the overall relationship and the quality of their sexual life. Assessing potential causes and exacerbating predisposing, precipitating, maintaining factors. Understand all these factors which is causing this problem and work together. If this is not your niche, you work together with another colleague. So, thanks to Dr. Avasti and Dr. Rao, they have given us this beautiful flow chart and an algorithm. What happens when a patient presents to you with a sexual dysfunction? So, if you have used the model of Plicit and the patient is now opening with a sexual problem, you have this beautiful 5 step flow chart. What happens if the person reaches to a doctor? You do a basic evaluation of the various, you remember the 5 domains, the bio, psycho, social, sexual, and spiritual model. You go deeper into this model, right? Then you start working on her comprehensive medical history, which is a man, and this has to have a sexual history and also medical history, a lot of other aspects also. So finding what is the physical cause, what is the psychological cause, what is the social factors which are affecting. Then you create a flow chart for the treatment, which is educating them, helping them to create a client-centered, goal-oriented approach, whether that requires medicine, whether it requires psychological treatment, or it requires both, right? And our final will be biopsychosocial evaluation of the sexual well-being and reaching a sex positive or a result-driven strategy, helping our patient. Okay, so this is, we've already talked about this, that the biological factors can be diabetes, hypertension, metabolic condition, drugs, other chronic conditions, obesity, of course, smoking and alcohol. We have other factors, which is antidepressant, cardiovascular drugs, which can affect the sexual functioning, lead to erectile dysfunction in men. Antidepressant can really hamper the arousal, can really hamper the desire. And of course, if there is no arousal, desire is not happening, the person is not feeling a pleasure. So it is indirectly going to affect the desire. And we have a lot of environmental factors. Lately, stressors, especially occupational stressors, have become a big problem causing sexual dysfunction. Imagine those IT professionals who are working 15 hours, come home dead and brain, and when the wife wants to be physically intimate, sex is not happening. So these are various occupational hazards which can affect one's sexual functioning or even the desire to have sex. Same diagram, but listen, here I'm going to bring your attention to the various subcultural factors, which is the religious background factors, negative messages since childhood, social media, internet, peer pressure. Let's get peer pressure, right? I have patients come to me all the time. Ma'am, I've heard that sex can be very painful. Oh, my friend said that I'm going to bleed. I'm going to have a prolapse. Whoa, look at the messages what this person receives about sex. No positivity. Do not masturbate. It's going to cause eye problems. Do not masturbate. It's going to drain your energy. All sorts of myth and negative messages. Socio-cultural factors. Is there an abuse in the relationship? Physical, sexual. Is the partner alive, or is the partner living in a distant occupational area? What is the familial and social support? What are the various stressors, right? We want to know everything about this patient. So evaluation becomes very important. Again, thanks to Dr. Avasti and Dr. Rao, this is an important aspect in evaluating of sexual dysfunction. We also, this is a nice chart from the similar article which talks about how can you distinguish between an organic causing organicity or a psychogenic factor in this person. Very commonly, if it is a younger person, we know it high probability this is a psychogenic problem. If it is an acute problem, it is probably going to be psychogenic. If it is situational, it is psychogenic. If it is intermittent, if it is fluctuating, if it is quick onset, usually, if it started after the partner had a problem, it could be psychogenic, but there are various other reasons, organic condition, which can lead to sexual problems. Okay. And again, from the same article, we want to look at what is the predisposing factors, what is the precipitating factors, what causes this, right? And what is maintaining this problem. And I'm going to give you a nice example of a female patient. The husband comes to us saying that the female doesn't want to have sex. She is not interested. She is always denying. And go deeper into the dynamics, we get to know that every single time the husband walks in the house when he has had couple drinks and he is just not by himself, he is not himself, she is not interested. So this is that. And what adaptive response she has developed is she doesn't want to have sex when he is drunk because he probably is abusive. He is smelling horrible and he is just not himself. Right? So we have to look into the predisposing factor, precipitating factor, and the maintaining factor. What is causing this adaptive response in that female? Okay, and we talked about this slide already, but now again, be very careful when you watch this video because this is going to be a big learning experience for you.
क्या हुआ?
सिला जीत दिए थे ना आपको, काहे नहीं लेते हैं? आज फिर जल्दी रहेगा। तो मुश्किल से महीने में 1-2 बार कर पाते हैं अब। ऊपर से हर बार गर्म करके ठंडा ही छोड़ देता है हमको।
बहुत गर्मी है, चकला पे बिठा दे। अरे त्रिपाठी खानदान की बहू हो, ये बेशरम जैसे बर्ताव नहीं किया करो बिना।
So wonderful video. Now, see and imagine the plight of this man who will come to you probably with erectile dysfunction or premature ejaculation, and you would want to start treating him. But you would forget that the wife has been so she has not been kind to him because she is always trying to put him down, and now he, the macho man, is like, oh god, you talk to me like this and I'm going to shut you down. So he shuts her down by saying, you are a daughter-in-law of such a reputed family. How could you, when you talk like a paid sex worker, how would you talk like a prostitute? So here is this dynamic of an husband who has already been hearing negative messages or condescending messages from his part, and he is trying to do the same. So she is now defamed by saying, oh my god, you being like not a very good person. She is not allowed to express her desire, that she is not satisfied. So very important dynamic here is shown to you, which can be used any point of time in your clinical practice where two individuals and how is their relationship. If you watch this program, I haven't watched it. This is by one of my other, but if you watch this program, you get to know that their relationship is not that great, because here she is suffering with not feeling satisfied, not having orgasm, not really having pleasure. He somebody who thinks that I've done a good job, right? I cannot be telling me that I have some sexual problem. It's a problem with you. So,
क्या?
okay. Now, what would you want to learn from this particular video is the psychophysiological model, which is a desired discrepancy. Clearly, in this video, this female definitely has a different desire than her husband. There is also a dual control of sexual interest and response, because she is trying to express that I'm not having pleasure. At the same time, he said, how the hell can you not have pleasure? What is wrong with you? We are talking about the excitatory process or the inhibition of the sexual interest or response. There is definitely inhibition because there is condescending conversation, there is suppression of feeling. So there is more inhibition than excitation. Now, inhibition of sexual response or sexual interest or response is an adaptive response. So here she has learned that he's anyway going to discharge fast. So I probably cannot even have pleasure. So very, very crucial attention to that particular video and understanding the psychophysiological model. Okay. Now, something very interesting which you probably will not hear from other people. What we tend to forget when we talk about libido and desire, club these two phenomena together and think these are such biological driven phenomena. Whereas, mind you, a person, a man can have the perf and still have no desire or still cannot have erection. Similarly, a female probably having all the factors not might not be interested in having sex because of what is desire, right? Libido or desire is only one component of desire. Libido or drive, one component which is very biologically aspect in sex is what is their erotic script or what is their cognitive component, what is the individual's belief, needs, desires, right? So even if these two individuals are having sex, but the erotic script is all about negating, all condescending, person is not going to have desire to have sex, then again, what is the intimacy connection? What is their motivation? Do you think either of these individuals are going to be motivated to have sex again? Absolutely not, because there has been such a drift in their sexual desire. There is such a drift in their libido drive or even in the erotic script. Their entire erotic script is very negative. She is not able to express. He is ready to shut her down. So this is a psychoeducation model, and you need to understand this because you're going to help your individuals, your patients, to develop a positive script, to develop motivation in their relationship, not completely focusing on testosterone, estrogen, or any other biological factors. So this is again, we have psychological and relationship factors which can lead to sexual dysfunction, medical, physiological factors, situational and cultural factors. So here, a beautiful dynamic which I'm again going to bring to your notice.
बहुत टाइम से आपको बताने की कोशिश कर रहे थे।
बीवी हो, शौहर बनने की कोशिश मत करो। नौकरी को ना बोलो कल से, घर पे बैठो चुपचाप।
So again, understanding this phenomena, this is called the power struggle. And mind you, power struggle, here is a power struggle of this man over his partner. That, hey, you are a wife and you're not supposed to work outside. This is your position and you are only meant for me to have sex. She has pain because if you watch this movie, she has pain, she cries, she lands up with multiple infection and multiple MTPs. Power struggle, guys. We tend to forget how to evaluate these concepts and how to treat these concepts. And there's another video which is similarly, which is again, I'm going to talk about what this dynamic of power struggle means. So when female, and we're going to talk about this in another video, but this is called an responsive. So there has to be a balance of responsive and adaptive, responsive desire and adaptive response. So when I talked to you about the alcohol phenomena, that was a negative adaptive response, right? And that leads to a negative response to desire. But imagine this beautiful partner coming with a bouquet and chocolates and treating his partner like a queen. She knows that every single time he brings beautiful flowers and chocolates, he's so nice to me. She has learned an adaptive response, and then her desire, which is a responsive desire, is developed to engage into an intimate act. So when you talk to a patient who comes to your clinic, you also want to understand what adaptive response has been going on in this relationship. We talked about the factors when there is excitations, what happens, and inhibition, what happens. So now comes a very, very important thing. So remember, we saw that video about this female who's not satisfied and she is counting like, oh my God, he can last for so long. Then we saw about a concept of power struggle, right? Now let's see something very, very interesting. And if you are somebody who wants to get into this field, or even if you're not, this video comprises of the entire sex therapy book. Here you go. I'm going to play. Please be focused on every word with this video is going to teach you.
Talking to you. क्या हुआ?
सेक्स सिर्फ बच्चा पैदा करने के लिए करते हैं।
शादी की है, फैमिली प्लानिंग तो करेंगे ना?
प्लानिंग कैसे? ऐसे मैकेनिकल सेक्स करके?
What do you mean?
तुम्हें कैसे नहीं समझ आता दिवाकर? मुझे दुखता है। Can't you see?
तो मेरे साथ अब सेक्स भी पेनफुल हो गया।
हाँ, सेक्स टास्क नहीं है कि फिनिश किया और टास्क खत्म। थोड़ा तो प्यार करो दिवाकर, थोड़ा फोर प्ले करो। मेरे भी कुछ डिजायर्स हैं। हमेशा सीधा शुरू हो जाते हो और खत्म होते ही मतलब
तो काफी एक्सपीरियंस्ड हो, सेक्स एक्सपर्ट। हाँ,
डिजायर्स लाइक कुछ है भी तुम में? किचन की बांस आती है तुम में से। और शक्ल देखिए अपनी लेटली। मैकेनिकल सेक्स।
Okay, so here we are going to talk about what do we do when we have somebody who comes to us. And here we are not really well trained in therapy. This particular video will break down every aspect of sex therapy for you. So here, if he is condescending to her, hey, look at me. She's, why are you not interested? She's like, is sex all about having children? No. It's hurting me. It's painful and you can't see. So how can it hurt you? Why would it hurt you? Right? At least do some foreplay. So remember, when we talk about sex therapy, foreplay is the most foremost thing. You teach the people to get ready for sex and to be part of this beautiful phenomena. So it's painful for me. You need to do some foreplay. We cannot have mechanical sex. It hurts me. So I need to be treated because I'm not aroused. Lastly, remember that he was talking about such condescending conversation like you smell. There's nothing to desire in you. Because for me, all sex is like I want to show my power on you. I want to have sex, and that is it. I don't care about your pleasure. Lastly, he walks out, probably causing a lot of body image issues for her. Like you smell, you look horrible. So you have so many things to work on when you talk about sex therapy. So let's see. Let's start here. So the first step to your treatment. First of all, treatment can be pharmacological and non-pharmacological, and especially when we talk about sexual dysfunction, we must first and foremost learn about all the non-pharmacological techniques because that can give you more results than pharmacological techniques. Okay, so let's learn various non-pharmacological techniques first. Psychoeducation and psychosexual therapy. Here, the first and foremost thing is learning about the sexual response cycle, anatomy, physiology, educating what can lead to sexual problems, build up a treatment plan, and teach them the benefits and importance of sexual pleasure in their relationship, not just sex. So, this is beautiful, and look at this video.
एक साल में 116 बार निशाना साधे। समझ में आ रहा है आपको?
आप गिन रहे हैं? इन्हें सही जगह पता नहीं है, ये गलत जगह घुस जाते हैं।
So guys, remember,
एक साल में 116 बार
however you want to undermine the importance of sex education, it is a very, very crucial thing because many a times even the most qualified people are not knowledgeable in what exactly is the inlet and the outlet. Okay, so sex education is a crucial point. Now, the various non-pharmacological techniques are sex therapy, individual and couples therapy, which involves a lot of experiments, exploration, experiential, enhancing techniques, right from masturbatory protocols to building communication, sexual vocabulary, sex mapping, sex diary, and sexual calendars. That is all aspects of sex therapy, individual and couples therapy. And is also body image and self-acceptance. Men come to us with, ma'am, I think my penis is too short, too small. Women come to us, probably I put on weight, that way he's not attracted towards me. So positive psychology and supportive therapy, encouraging them and developing a positive sexual or positive body attitude is very important, and that begins and ends with open communication with your partner. Focusing on pleasure and satisfaction, not about reaching orgasm, right? Of course, orgasm is important, but pleasure, enjoying the journey with each other is much, much more important. Did I reach orgasm? Did I ejaculate? How much time did I stay? So giving them the concept of, are you enjoying each other's company? Are you enjoying this bond which has been created? Very important. We have cognitive behavioral therapy and mindfulness based cognitive behavioral approaches. In behavioral approaches, just a few which I have named here, but there are so many. We have systematic desensitization, especially when there is pain, there is phobia, right? We have vaginal penetration containment techniques if the female has pain or desire issues. We have movement during containment, especially in case of female sexual problems. We have different types of you with premature ejaculation, or even when a man comes to you with erectile dysfunction. Non-surgically, non-pharmacologically, there are so many things you can do to help your clients. Remember, we just saw a video about the power struggle where the man was showing power. Let's look at this.
She's young, but you know its importance. Radha, I need you.
No, Shubha. Not tonight.
Headache? Do you need aspirin? You don't want?
No.
Okay.
So here, remember, not only the husband can show the power struggle, even the female, where she says, you know what, I don't want to give you sex, so I'm going to say no. I'm going to say no to sex. Probably I'm going to complain of pain, lack of desire. And similarly, the other partner, he just thinks that, oh my God, she would need and I would be anytime available. There is no arousability, there is no foreplay. But with the power struggle concept in this video, we also learned something which is called a sexual orientation. These two women are sexually and intimately involved with each other. So always remember, when you are working with couples, you would want to understand the dynamics, the power struggle, and also sexual orientation. Right? So commonly used, this is one of the very common sex therapy strategies, which is called as a body mapping, or also called as a sexual mapping. This was designed or invented by Dr. Hartman and Titian, which is a mindfulness-based strategy where you start learning about one's body, the areas of the body which are erotic, sensual, sexual, and also which parts of the body are not really fun. And this could go stem deeper into negative upbringing to sexual abuses. So this is body mapping techniques. We also commonly have heard about the sensate focus, which begins, of course, with sex education, psychosexual education, and starts with non-demanding, just exchange of touch, to going then into intercourse. So this is called as sensate focus by the MNJ, Master and Johnson. And this starts, see, the steps for sensate focus is right from communication to non-genital touching, just exchanging touches, and then going deeper into intercourse and penetration. Okay. Another thing which you have to also understand, if you have tried everything and you think, ma'am, the techniques, the sex therapy techniques are not working, you can also use accessories in your treatment. And accessories are not sometimes only used for treatment purposes, but also to enhance the sexual pleasure between the two people. So we have accessories for men, we have accessories for female. These are different types of clitoral vibrators, wands, and this is an O nut which is put on the penis, so the male partner can have stronger erection because it holds the erection, also helps to control the ejaculation. So accessories are myriads of accessories. If the male partner is suffering with premature ejaculation, we have the P training cups or the masturbatory cups or the flash torches. If the male partner suffers with erectile dysfunction, we have vacuum devices. If the female is not feeling stimulated, we have these different clitoral stimulators. Now, remember, another accessory is If each other do not want to give oral pleasure to each other, there are different devices even meant for those, where you can use devices and they mimic oral pleasure. Now, we talked about the non pharmacological techniques, we talked about accessories. These are different positions. So, this particular position is very commonly used for female pain. So she doesn't want to be penetrated because there's no control, and she doesn't want the man to be on top. So she can be on top. So she has better control of the penetration, and she can control the movement. If if the male partner has joint issues, if there is handicap, challenges, this is a nice position, and this is a beautiful divine lotus or the cosmic chair position, which is picked up from Kama Sutra books. Here, this is a more shallower penetration, also called as the saucy spoon position. This is a miraculous position. This is, I'm going to teach you more on this, which is called the missionary position, where the two bodies are connecting with each other at different points, and here no penetration happening. It is just oral pleasure, which is called the 6 and 9 position. So we learned about the non-pharmacological techniques, we talked about the accessories, and these are different positions, and you can use them all together or you can use them individually. Yes, this is what I was talking to you about, which is called as a miraculous missionary position. This is called as a cat technique, which is the coital alignment technique. So let me show you what this is. Okay, so I think I don't have the picture, but coital and alignment technique is where the male is on top, but in a position where he has more body connection with his female partner, and the connection is in the way that he can stimulate the clitoris while he is doing the movement. So that is the coital alignment technique. Can be difficult, but when the male partner learns or the couple learns, it can be a very pleasurable technique. Now, sex is all about, you have to encourage each other. You should be ready to explore, should be ready to experiment. If one thing doesn't work, the other thing works. It should be encouraging each other in a relationship. We need to embrace each other's challenges and each other's difficulties, and we need to evolve, right? As I told you, not just one technique. There are so many things you can help your patient with, and one should be ready to experience love, experience bonding, experience physical pleasure. Now, we talked about the various non-pharmacological, but there are so many pharmacological interventions which can be done. So, if there are females, there are various types of hormonal. We have gels, pellets, we have flebanserine, we have Aleve. With men, if they have erectile dysfunction, we have PD5 inhibitors, which is the first line of treatment along with therapy. Remember, your treatment is going to fail if you do not involve non-pharmacological techniques. So if we have females, we have whole set of different pharmacological agents and hormones and injectables which we can use. If we have males, we have different set of techniques and pharmacological agent in terms of hormone. After detailed evaluation of the hormonal profile, we can suggest hormones. If the female is postmenopausal or menopausal or perimenopausal, then different hormones can be given so she doesn't have pain, to take care of the dryness, to take care of the atrophies, right? But if the man has been suffering with some hormonal issues, we can definitely give him some hormone. Men can be given injectables. We all know about the Trimix, which is given to and which is given to men for instant erection. This acts on a different concept, but again, we have various surgical options for men, which is they can use what is called as devices, penile implants, right? And if there is other causes which is leading to erectile dysfunction or any of other problems in the man, there are surgical options available as well. So in general, we have to remember that there's not just one technique you can help your client, whether be it man or female, a female or men. You can have so many different strategies you can give. I almost tell my patients, once you come to me, you will definitely take something back. you will definitely experience differences, because there's not one strategy, there are so many strategies. So men who come to me and say, ma'am, I really don't want to use medicines and I don't want to go for surgery, boom, you have penile pumps, right? If you're suffering with PME, there are different devices which can be given. You can be given antidepressants which can help you better control your ejaculation. If a female comes to you, ma'am, I'm not interested in having sex. We have sex therapy, we have couple therapy, we have different, right from lubricants to arousal gels. We have so many things which we can give. And if things don't work, then we can teach them what is different forms of physical intimacies. We have sex, we have self pleasure, mutual pleasure, fingering, different aspects of foreplay, dry humping, or just genital rubbing, non-penetrative forms of sex, penetrative sex, but in different areas of penetration. And there are so many things they can try to have sex. Lastly, I thank everybody for this patient hearing, and I hope I have done justice to this overview of sexual dysfunction.
Thank you. Thank you very much, Dr. Anita. I must say, truly engaging, and I have learned personally many things, and I like the way you brought in the videos to explain the situations. And there's a particular slide I really liked, and I must mention this to the postgraduate trainees, where you showed us that, where you've integrated the factors, the models into that relationship triangle. It's such a clinically relevant, a very quick tool, really, that can be used when we are talking and discussing and showing it to the 5 models together by 5 dimensions, alongside it's the Boston model you've used, isn't it, in that clinical slide? Yes. So I think that's very interesting. Of course, as a chair, I will have other questions, but I would like to first invite none other than Professor T.S.S. Rao to lead on from here. Professor Rao, please.
Suddenly saw this message today morning, and I'm really very happy that I am here. Almost always listening to Anita is something extraordinary. Each time, so many programs I have attended of her training. Each one is something special, and each one is a good learning experience. Very recently, she was at Mysore, and many of the times, how actually this female sexuality to be managed. In fact, she is really sex coach. That word and practice equally applies for her techniques of teaching. And I'm really honored that I was able to listen to. Really good. In fact, let us see. In fact, anything to tell about Anita is it looks like so official. She has such an expertise in this field. Thank you, Anita.
Well, it's the first time, ma'am, I've heard you, and I must say, I look forward to more such interactions and engagement.
For our fellowship and diploma program, she is one of the backbones.
Right. Fantastic. Well, if it's okay with you, ma'am, we'll take some questions from the audience and then we can discuss it. There aren't any questions. There's a comment in the chat box from Dr. Ashok Kumar, who says, thank you, sir. If you are here, if you could also unmute yourself and switch on your camera whilst I read out your comment. It says, stigma or shying away on sex matters is prevalent in practicing medical practitioners. Still, medical education in India has not removed stigma on sex matters. I guess not just India, ma'am, you'd agree. It's still a worldwide thing, isn't it? Yeah. So your views, I mean, is Dr. Ashok Kumar here?
So
okay, ma'am, on that topic, yeah.
Yes, of course.
The audience can't unmute themselves or...
All right. Okay. Right.
They can only post in the chat box.
Okay. So kindly, all of you, please start posting your questions in the chat box while ma'am sort of comments on this question. Thank you.
So, rightly said by Dr. Ray, this is not a problem just in India, it's worldwide. But the recent study, there was a large study done by the Massachusetts Aging Group, and they had published this entire research which showed that once the physician is comfortable with the topic and the physician opens, patients are willing to talk. In fact, that research was so interesting that even the age group of 50s, 60s, and 70s want to discuss their sexual problems when the physician opens themselves. So that's what this explicit model is so fascinating, right? You give your patient permission. You give their patient, how's everything? How is your intimate relationship? Do you want to discuss about your sex life? So once you open, that shatters that barrier and the patient will be willing. In fact, if you really want your patients to come back to you, please start asking them about their intimate relationship. And this has to be without a reluctancy, with a very open question, open ended question. It's like, do you want to discuss anything about your physical relationship? How is sex life? Are you satisfied? And you will see that this patient comes to you again and again, because here is a doctor who cares about this special, very intimate aspect of me. So, uh, giving you the right information, this is not a problem just in India, it's worldwide, but it is your strength who's going to open. You're going to open to your patient and ask, I'm willing to listen to you. Do you want to share?
Yes, absolutely. I think it's acknowledging the fact that it is a matter of their hesitation. It's a matter of shyness. Sometimes it's also a matter of not understanding what's happening, feeling totally lost in the circumstances. Because many a times I've seen patients, ma'am, who just have accepted. They can't even, the mindset has become over a period of years. So acknowledging and accepting, well, they have surrendered to their situations. And even thinking becomes a taboo in that way, that there can be a beautiful expression. And we see people in their middle ages, just like sailing ships, they're just living under one roof. They are, yes, of course, when it comes to household chores or finances, talking about children, life is smooth to the outside world. But when you check it out with them individually or together, we realize the dissonance there. I think you said, there was a nice phrase you described, the discrepancies, isn't it, in the two sort of things. So that becomes so obvious. And it's just that it triggers like a floodgate opens, like, you just give them one question. And there you see, the patient came for something else. And here we've gone to the second consultation is on something very different.
Yes, yes.
And
And
something, yeah.
this is going to, I'm going to give you all one example. So I was seeing this patient who lost his wife at, I think, the age of 45 due to cancer. And all the rest of his life he spent was raising the kids, and kids getting education and all sorts of things. And then he comes to me at the age of 65 and he says, I really want to talk to you about how I feel. I miss the connection. I miss the skin bonding. I miss that skin to skin touch. Every night when I sleep, I'm sleeping with my pillow and I don't get erections anymore. I am missing that aspect of me being a man that I am not. And we started working on sex therapy. We put him on PD5 inhibitors. And, just a week ago, he wanted to talk to me and he's like buzzing me, and he calls me, ma'am, I want to share a good news with you. I'm like, okay, what is it? He said, ma'am, I've started going for walks regularly and I met this wonderful lady who's my neighbor and we just connected with each other. And ma'am, I don't want you to judge me, but you know what? She approached to me. She approached me for an intimate relationship. And I wasn't really sure how it's going to be acceptable because I'm a widower and my children are all grown up and I'm supposed to be a spiritual person right now. But imagine that giving him that assurance that it's completely okay because you want it. I don't want you to suppress his feeling. And he comes back to me like, ma'am, what I felt today, I haven't felt in years. I said, I feel alive now. And this man comes to me like this is a South Indian guy who found me on internet and reached out to me and comes to me in that typical matha and dhotar and everything. And he's like, I want to thank you for what you've done to me. So guys, it's not the age which is going to be a problem. It's going to be you, the specialized physician, who's going to give that patient that courage and encouragement.
True. And the question is, what is the problem? Is it just the intercourse that we are looking at? Because we have to understand how we are defining the problem. If it's just the intimacy, the pleasure, the feeling of goodness, the satisfaction, of just a human contact and a human touch, then it's a much different world than if we think sex is equivalent only to the intercourse and or just the purpose of having a child or raising, having a baby. If that's the whole purpose of sex, then it defeats the whole, our ancient traditional Kama Sutra concepts get, things as well. And interestingly, I have a patient whose mother-in-law keeps on texting me and reporting to me every day, well, doctor, they did have sex today or they didn't have sex today. And I'm thinking, well, it was good that, to be very honest, this couple came to me because their mother-in-law was worried, okay? But now I think she's becoming more of a hindrance to this whole situation than of facilitating it. So it's a work on not just the two of them, it's a work with her, helping her to detach and not keep on sending me texts. So this is so complicated sometimes, and we have to look at all the people who are additional partners in this whole relationship triangle. Yes. Well, we're still waiting for questions. I know there's someone's request, which is Dr. Patel. I think these recordings are always available, as Dr. Rashmin has said. There's a question on patriarchy on human sexuality, ma'am. There's another comment on that. I'm not sure if it's a question or just something on comment or someone would want to know about it.
I think if you are talking about patriarchal system on human sexuality, things have changed. Trust me, things have drastically changed. Where women, in fact, there was a time when it was always a men domain, but with female, now women have started voicing their desires and needs. And we just saw that video where she says, what's wrong with you? Are you not having Shilajit? I told you. I'm always not having pleasure with this. I'm not satisfied. So women have started. In fact, to be very honest, and I don't want to, and I want to sometimes just stop saying things, Dr. Ray, but I want to say it, and I tell it all the time. I sometimes feel sorry for men. I really truly feel sorry because women have become so brutal and so open to their sexual needs that, like, come on, what's wrong with you, right? Your dick is not standing anymore. No, I'm not feeling pleasure and I'm probably not going to have sex with you. So women can be so brutal, and then that psychologically affects our men who then develop PME and erectile dysfunction, and at times lack of absolute desire. No, I'm not interested in having sex. So that system has changed. No. So women as just sexual object, there are, see, we always have those sector in society, those individuals in society who treat women as an object, as a pleasure object, and I've shown you those videos, what happens. But yes, things are evolving and changing now. And things have not only been changing on the higher socioeconomic strata, but also in the lower group where when men are really concerned if their wives are having that, in fact, not the wives, in fact, their partners are having pleasure. So things are changing, my friends. My PG students, things are changing. Let's not have that old mindset where, it's a patriarchal system. It's all about man. No. You just saw that video of Mrs. G, which says, no, I'm going to talk because I'm not satisfied. And sometimes women have chosen even to walk out of these relationships where they feel, I think they should give them more chances. They should come to people like me where I can help them, but they choose to divorce and separate. But things are changing, everybody.
Thank you. If I request Professor Rao to sort of give his final comments, maybe, because I don't think any more questions are here. So, sir?
Of course. It was something real good learning experience, and more than anything else, she has that capacity to trigger thoughts in physicians to look at the problem in a different way. That's one important point. See, even in our PJs, when we ask them to work up a case, a depression case means they will inquire about libido. In conversion disorder means they will inquire about sexual abuse. But these are all very small histories. What we need is a very comprehensive understanding of the problem. That is one important aspect. There was one study wherein at least about 10% of the individuals would like to talk on sexual issues in some special clinics. But when you ask extra one question, do you have any sexual concerns to talk about? This number increases by about 50%. That is one. And there is another scale from Mayo Clinic. Only 4 questions are there. One is to break the ice. Do you have any sexual concerns to discuss? Do you have any sexual problems in the last 6 months with men and women? Of course, that is the third question. The fourth question is, do you have any interest in looking into this particular matter? I think that fourth question, exactly the wordings I'm missing it actually. So there are many such efforts to make physicians understand that these are all extremely important, and you definitely need to. See, even in our clinic, what happens? Somebody has written some antipsychotics, antidepressants, but again, they'll come to my chamber, they want to ask one extra question. That means they are concerned about sexual issues. The non-compliance and lot many other things what we talk about are related to this particular fact, why even our range of sexual disorders gets into difficulty. I'm extremely happy she was quoting our first article in 2017, Management of Sexual Dysfunctions, Ajit Avasthi, Sandeep, and myself. Then subsequently, of course, there are about 5 different clinical practice guidelines related to old age, consultation license, psychiatry issues, drug-related management, women-related, and a whole lot of other such things have come up. They're all easily available, open access in Indian Journal of Psychiatry. I request the PGs to positively definitely have a look. And as president, only last point, a special comprehensive clinical practice guidelines is going to come up about each individual disorder. We are going to try to look into, including evidence-based data that is available. One is common problems, but more than anything else, say what happens in case of schizophrenia, depression, mania, alcohol, and other related things. Comprehensively, about 15 chapters, what actually has been designed, and Dr. Shiv is leading this particular issue, and Avasthi and Sandeep are there again in this process. Thank you very, very much. Anything sexual, I am interested. From Anita, of course, it has that special flavor altogether. Thank you so much.
Excellent. I think Professor Rao's mention of the 4 questionnaires from Mayo Clinic reminded me of the days when Cage questionnaire for alcohol started, if you remember the 80s, and it had to be drilled down, because a lot of people didn't talk about alcohol or substance use, but this 4 questions started people exploring, gave a platform and an opportunity to discuss and talk. So I guess these, as you said, the implicit model, just the permission to talk, or the Mayo questions, the 4 questions, will just set and open the doors to longer term discussions on these issues. Well, thank you very much. On that note, I think there has been a comment as well, just that, Dr. Rupendra Sharma said that, yes, one harsh comment, we agree with you, sir, that one harsh comment after an episode of PME does make it a lifelong phenomenon. And it's our duty to change this, for even if we touch one life and change one relationship, we have done a small bit to this long journey. Thank you, ma'am. Thank you, sir, for being with us. And on this note, I'll hand this session over to our organizers.
Thank you, ma'am, for coordinating the proceedings today. With this, we come to an end of the session, which probably all of us wanted to continue with more and more knowledge about on this subject. So with this, on behalf of the organizing team, I extend my sincere thanks to our esteemed chairperson, Rajeshri Ray ma'am, and also Professor TSS Rao sir, for graciously presiding over the session and guiding us with their experience. I also express my heartfelt gratitude to our respected speaker, Dr. Anita Shyam ma'am, for a very well delivered talk, with especially with those videos which made the understanding of the subject quite simple and lucid. My thanks to all participants for their active presence and engagement, and to organizing team for their efforts behind the scenes. Thank you all once again.
Thank you.
Thank you very much, Dr. Anita Sham. Thank you very much, Dr. Rajeshri Ray. Very kind of you to make the time and be with us today. And obviously, a very special thanks to Dr. TSS Rao, who so graciously joined us today. We hope to have you back on this forum, sir, in this capacity of a chair as well as a speaker sometimes. I know you are a very busy man these days, but I am sure you will be kind enough to grant us a little bit of your precious time.
There is always time for sex.
Thank you. Thank you very much, all of you. Have a great evening ahead. Thank you so much.
Thank you.